Well, hello everybody, welcome. Hopefully you can hear us. It's really nice so many of you can join us across here. As we've just sort of experienced there, please make sure you popped your microphone off. However, we would love to see your smiling face. We were just talking before, so much of communication is in eye contact, virtually admittedly, and body language. So if you can see your smiling faces, we can see if you're engaged, we can see if there's things that you may not understand, we can see when there's moments of aha and understanding, and that was a really, really nice way for us to engage. So of course, if you're eating your lunch and you don't want to be on camera, that is absolutely fine. But if you would like to, that would be really great. Now, welcome everybody. My name is James Waldron. I am a GP working in Nottingham. I'm a very much portfolio GP. I wear many hats, and one of them is with the Training Hub, bringing you CPD and education. This is one of the first of our sort of series on neurodiversity and mental health. We've got one next week and one a couple of weeks after that as well on personality disorder. So we've got lots and lots of things to help support you in your practice on such a challenging and important topic. A few more things about the Training Hub. If you are not signed up to our newsletter, please sign up to our newsletter. I will pop it in the chat, or Denise will do that. She's lurking in the background somewhere. Pop that in the chat. If you don't have the app, it's called Grow Not Primary Care, and it's an absolutely great way of organising and finding out about CPD directly to your phone. Nice and convenient. Don't have to trawl through all the emails. You just know you get the good stuff directly to your phone, as well as a lot of education updates too. So you've joined us today for a session on ADHD, what it is, what it isn't, and what we can do. And I'm really glad that you've made that choice today. We've got a wonderful program over the next hour and a quarter or so, hour and a half, of course. If you've got to get back to clinics, please get back to clinics. You know, we know how pressured the day can be, but we would love you to interact with us. And if you want to do that, please pop your questions or thoughts or ideas or any resources you've got or any consideration to have in the chat, because, you know, with so many clinicians around here, we've got so much background, and often the answers are within us, and things that you tried might be an aha moment for someone else. So you didn't come here to listen to me. You came here to listen to our wonderful speakers. So it gives me great pleasure to introduce you to Dr. Blandine French, who's a senior research fellow at Nottingham University. And she's going to be taking us through this very, very interesting topic. Welcome, Blandine.
Thank you, James. It's nice to be here. So shall I get started in sharing my presentation?
Yeah, that would be great. Yeah. So we'll look at I'll keep an eye on the chat for any questions throughout, but we'll probably come to them towards the end. Although yeah, please make sure that conversation's going to keep us all stimulated and engaged throughout this as we munch on our lunches.
Okay, just so you know, I can't see the way my presentation is working. I can't see questions, or I can't see hands up, or I can't see anything from the Teams. So if anyone wants to interrupt me, please do so.
Sure.
Yeah, James, if you want to get anything, I'm more than happy to stop and answer questions as we go along, if that makes more sense for everyone. Sometimes it's easier like that. It's supposed to be quite informal and more of a conversations around what's what. So yeah, don't be afraid to interrupt me or ask more questions as we go along.
Fantastic. Yes, I'll jump in as needed. Then, in which case, Blandine.
Yeah, brilliant. Thank you, because I can't see anyone. So just for a little bit of background, I always like to be quite transparent with the kind of expertise that I'm bringing when I talk about ADHD. I was diagnosed with ADHD in adulthood. Both my children have got special needs. And getting a diagnosis allowed me to go to university and get my degree in developmental psychology and eventually my PhD. I've also been doing support groups for adults and parents for the last 13 years. And I lead the local healthcare neurodiversity network here in Nottinghamshire. But none of this is my main job. My main job is a little bit like what you were saying, James. You wear different hats, but my main job is as a senior research fellow in ADHD here at the University of Nottingham, and I specialize in access to care and care pathways. I'm currently doing a fellowship on the economic cost of undiagnosed ADHD and autism. So today I'm just going to talk to you a little bit about what ADHD is and go through some case studies, the local care pathway, and the role of primary care within these pathways. Now, this training is based on a program that I developed with GPs back about 4 or 5 years ago, and it is accessible on this link. And so in terms of the actual ADHD knowledge I'm going to present today is it's a lot less than what is on this program. So if you want to find out more details or more information on ADHD, please go on that. It's free. It lasts about 45 minutes. It's been accredited by the Royal College of GP. Sorry. So it's part of the CPD program for the RCGP. And it's just readily available. So yeah, just please refer to that program if you want afterwards. So what is ADHD? I always like to start by gauging a little bit about the audience. It's very hard when I can't see you though. Let me see if I can just minimize everything. So ADHD is caused by excessive sugar consumption. I really do think about it and think with that. Usually when I do this quiz with students, there is a paddle that they can answer on the screen, but it just wouldn't work with the way we are. But this is one of the main stigmas and misconceptions about ADHD. So I quite like to always go through some of these that tend to be quite strong. So this is false. What we do know is that the environment and things like diet and exercise can influence the expression of symptoms, but it doesn't cause it. ADHD is a genetic disorder and biological disorder, and nothing causes it, but certain things can make the symptoms a little bit better or a little bit worse. Children who take ADHD medication are more likely to abuse drugs. This is one of these misconceptions that usually is still strongly present. So this is false. ADHD medications are controlled medications, and just by the nature of it, you tend to think that they are they can be addictive or they can lead to further addictions. But many studies have shown that actually it has the opposite effect. Taking ADHD medication as a child, and the earlier you start getting, the better the outcomes. So having ADHD can lead to a lot of substance abuse, and I'll mention it a bit later on, but being treated and supported for ADHD through medication, especially in childhood, prevents this kind of harder outcomes to happen. ADHD is I can't say that word. I can't say that word. I'm going to skip it. It is a genetic disorder. And again, I'm going to touch down on that as we go through more information on ADHD. But it is you're born with or not. It's not something that you catch or that anything causes it. People with ADHD often struggle to accurately estimate time. Yes, they do. It's called time blindness. And it's just a concept where basically ADHD affects executive functions, but this concept of time is really messed up, where you can hyper-focus and think you spend just 5 minutes on a task that's taken you 3 hours, or the other way around, or really struggling to think, okay, well, I need to empty the dishwasher. Is that going to take me half an hour or 5 minutes? Just not grasping the concept of time. ADHD is a result of poor parenting. I think for my first point, I will hope that most of you will know the answer to that. But yeah, it's wrong. Again, nothing causes ADHD. ADHD is not the result of anything. We do know that the environment again impacts the expression of symptoms and the impairment with ADHD, but it doesn't cause it. Now, just to give you an example of parenting, the way parenting can influence ADHD. So, for example, you take two children with the same level of impairments and the same level of ADHD. I mean, ADHD doesn't really work like that. You don't, but let's just say two boys, same age, same and same level of impairments. And you have one boy who grows up in a house where he shares a bedroom with his sisters. His mother might be working night shifts and don't have time to spend doing his homework or doing many activities with him. He does not have a garden because he lives in a flat, so he has nowhere to go and like release some of the energy after school. Or and you take the same boy, but that will be in a house where there is a garden and there's a trampoline. So after school, he spends half an hour on the trampoline, and his mum has got time to spend, doing the homework and really supporting his learning, supporting his regulation. Well, the outcome of these children will be different. And this is where parenting affects it. It's not a result of parenting. It's just parenting can make things better and can make things more hard. And this is why when we're working with children, we work on what we call parenting program. And this is not to say they're bad parents. You just say you have to parent differently and you have to approach things differently. So I hope I'm not getting anyone too confused. But yes, research studies have shown that the brain of individuals with and without ADHD are different. So it's in terms of white and gray matters and in terms of neurotransmitters, mainly dopamine and noradrenaline. So the way dopamine is, the reuptake of dopamine happens in the brain is very different. It's not atypical, and which is where the ADHD medication really help. It just help putting people with ADHD on par with an atypical dopamine brain, and the same with noradrenaline. So that's where the medication kind of helps. But there are definitely differences in the structures and in the function of the brain. So it has three main diagnostic features, which are impulsivity, hyperactivity, and inattention. ADHD only occurs in boys. I mean, this myth has been, I don't think there's that many people that still think that, but it's definitely wrong. In boys in childhood, the ratio is usually 4:1, but in adulthood, it tends to even out a little bit more. And this doesn't mean that girls are getting ADHD as adults. It's just girls are showing the struggles with ADHD, tend to show it more in adulthood, where, they might have their first relationship, they might leave uni, big life events happen and they're struggling a lot more. And this is when you see the impairments that come with having ADHD. But girls tend to be more inattentive, while boys tend to be more hyperactive, which means that girls tend to get missed a lot because they're daydreamers and they look at the window during their, during the school time, where the hyperactive boys tend to be a little more disruptive, so their behavior is more obvious to people. People with ADHD do often struggle to make and retain friends. And the same with autism. Social relationships are really, very different for people with ADHD. And it's a mixture of being quite impulsive and maybe sometimes saying things before you think, being really full of energy, which doesn't always work in certain social situations, like constantly talking or I mean, there's a lot of theories for why that is, but it's definitely and when I work with children and with parents, the impact ADHD has on social relationships tend to be the main problem for children. Not being invited to birthday parties, not being invited to play football because it's just a bit too much, and this really, really impacts their mental well-being. ADHD behavior is not a result of underlying brain damage. It is not something you grow out of with the right treatment. While many studies tended to show that, that there's a prevalence in childhood and a prevalence in adulthood that's a lot less. People can grow out of it. You don't grow out of it. What does happen is with the right treatment, you can learn to manage it to a place where it's not as impairing. And some people carry on for a long time not being impaired, so it looks like you don't have ADHD anymore. However, what we're starting showing more and more through upcoming studies is that as soon as a big life stressing event happens, those impairments come back. So you will have, children that have really learned to manage their support, they've got strategies, they're just really not affected by their ADHD, and it might look like they've got out of it. And then something like a divorce happens, a death, grief, or change of job or moving house. That will when everything crashes around them, and then you will see the impairment again. So this kind of idea that you just get better until it's gone, it is not real with ADHD. And finally, stimulant medication can make individuals with ADHD less hyperactive. And this is what I was explaining with the dopamine and noradrenaline, the way it evens out the brain to a place that is the same as a typical brain. Is because you have this deficit in how these neurotransmitters travel around the brain. It makes you less hyperactive, it makes you calmer, it makes you able to pay attention, even though the name stimulant medication seems really counterproductive compared to what it does, but for ADHD, that's what it does. So, well done on getting all these questions right. I'm assuming you've been answering in your head and you knew that already. But let's just go through some of the things again. I've just realized I haven't updated my slide. So 3 to 5% of children will have ADHD, that's the prevalence, and 60% will carry on having issues in adulthood. Now, this is a really old statistic, and it's being used a lot in evidence-based teaching. But there's many studies that show that this is not true. And this is what I was explaining. You don't go out of ADHD. I need to take that out of my slide because we've shown that it's not relevant anymore. Well, it's not true anymore. It affects both boys and girls. It's highly genetic. And it's a brain difference in structure and dopamine. And it often co-occurs with other disorders. So the prevalence of ADHD alone is usually the exception rather than the rule. So I didn't add this slide, but about 30% of people with just have ADHD. Usually the most prevalent comorbidities are autism, anxiety, depression, and dyspraxia. So always think about, okay, there is ADHD, what else is there? Because that would be the norm. We tend to diagnose from 5 years. Usually we tend to treat from 7 years, and it can be treated with medication, with pharmacological and non-pharmacological interventions. For adults, these are usually psychoeducation programs and peer support groups program for the non-pharmacological ones. And for parents, these are parenting programs. There's quite a few programs out there developed for parents. And again, it's not about telling them they're bad parents, it's about teaching them how to parent differently. So I've got 2 children with special needs. One has autism, one has ADHD, and I parent my children very differently, even in the same household. So it is about adapting your parenting. There are different rules, and there would be different approaches just because of the way they work. That's just the only way to do it. So in these videos, we filmed these videos as part of a research study that I did. They're based here in Nottinghamshire, where we try to show what does it look like to have ADHD on a day-to-day basis. So you have a children version and an adult version that you're welcome to watch in your own time. where you've got adults and families talking about what is it like to live with ADHD. And there are different forms of impairments across the lifespan. And we tend to think of ADHD as something like, you're struggling to concentrate and you're struggling to pay attention in class, or a little bit hyper, or a little bit energetic. But the way this is affected really changes throughout the lifespan. The way the inattention affects you, whether it's at a school level or at a work level or in your relationships. It changes throughout. I forgot to mention, so the key three symptoms are inattention, hyperactivity, and impulsivity. And you can be diagnosed with three different types. You can be diagnosed with an hyperactive type, an inattentive type, or a combined type, where both are equally impairing. And as I said, girls tend to show in a more inattentive type. And boys tend to show more hyperactive, but you will have hyperactive girls and you have inattentive boys. This is not a one size, it's not as straightforward as this. And I mean, it's not very scientific, this slide, but I do like to share it because my clinical experience of working with groups, whether adults or children or parents, is, we tend to focus on the inattention, the hyperactivity, the impulsivity, how to manage in a classroom. Okay, you've got this child who keeps getting out of his chair. How can I get him to sit down? How can I get him to do his homework? And there's a lot of focus on academic achievement and behavior around ADHD. What we don't tend to see and what we don't tend to think about, especially for the diagnosis and support process, is all the other things. So, for example, with sleep, 60% of people with ADHD will have sleep issues, whether it's going to sleep or staying asleep. It's hugely comorbid with ADHD. Sensory processing difficulties, so that tend to be associated with autism. But we know that it's highly prevalent in ADHD as well. So, really loud, not liking loud noises or lights or the feel of certain fabrics. And again, we don't tend to think about that. Emotional reactivity, emotion dysregulation, reacting very strongly to certain situations, having meltdowns. I mean, my 7-year-old still has meltdowns like a 2-year-old. Something happened at school or something. It's just very strong emotion. And usually by the mid-childhood, teenagehood, you will see a lot of anxiety and depression. And now when you work with people with ADHD, the anxiety and depression, the problem with sleeping, the problem of emotional regulation is what's impaired them the most. If you ask a child, do you want to be able to sit still in class or do you want to have friends? They want to have friends. If you ask a teenager whether she would prefer being able to sit through her exam, or she would like to not be as anxious and depressed and have all these mental health issues, most of the time the mental health issues have the strongest impact. So this is just to get you to think about the part of ADHD that's not part of the DSM-5, that's not part of the diagnosis criteria. But we do know there's been many studies that have shown, that evidence the overlap with all these things, and how, for example, in your practice, this is what you may see. You will see someone who really struggles with sleep, especially if they're stressed, especially if they're going through a divorce or they're going through problem at schools. So can you support the sleep? It's not necessarily about supporting the ADHD, the inattention, but can you support the sleep? Can you support the anxiety? Is that something you can do in terms of managing their emotions? So for me, it's very important to highlight this because there's lots of ways you can support what you don't see, but you might not think of it as part of the ADHD, the support that's needed for ADHD. So we conducted a systematic review, an umbrella review last year. So an umbrella review is a review of reviews where we've summarized over 1,500 studies in one paper. So we looked at all the different risks associated with having ADHD, and we summarized them in 3 different topics. So the links with mental health, physical health, and other impacts. So physical health, I mean, there were some risks. I've been working with ADHD for 15 years, and I still don't know. We know the link with sleep, but I never realized the link with teeth. So there's a lot of evidence around overall health, teeth issues, and the impact this has on the very strong overlap with ADHD, increased risk of accident and injury, high instance of eating disorders and obesity, and drug abuse and substance abuse. So studies, I mean, what stands out for me is that I looked at the studies in drug abuse clinics, with rehabilitation clinics, and in some of them up to 60% of patients, when we screened them for ADHD, had undiagnosed ADHD. I mean, these risks are there. We know that alcohol abuse or substance abuse is linked with ADHD, but usually it's a self-medication process, especially with cannabis, for example. A lot of people smoke cannabis because it gives them this calm brain that you can only get through ADHD drugs. So if you're not supported, this is where you will tend to go to. But it's really high. And again, I just wanted to emphasize all these, because this might what you might see in your clinics. And the same with accident. There was a really nice study with accidents where they went to an A&E, they just sat at an A&E pediatric hospital, and they saw over one evening, over a week or however long, the different groups of children. And you had children who came in because of appendicitis, and you had children who came in because of accidental injuries. And in the appendicitis group, you had the normal prevalence of ADHD of 3 to 5% of the sample, but in the sample group of accidental injury, it was 65% of them had traits of undiagnosed ADHD.
Blandine, sorry, I was just wondering if I could ask you. So you mentioned about people turning to cannabis. Does it tend to be that, because I've had a case recently where someone was more or less self-medicating with cocaine. Do people tend to turn to stimulant medications or sedative medication? Because at least initially, a lot of the thing about cannabis is quite sedative, whereas of course, amphetamines being used for ADHD are stimulants.
So do you mean stimulants drugs? Or
stimulant drugs, yeah.
Drugs, yeah. Both, actually. I know some people who get, I mean, it all depends on the people, but I know some people, I mean, the typical ADHD brain is a very overactive, non-stop thinking. This hyperactivity is like just always thinking. I mean, you wouldn't believe the amount of adults that just lay awake at night, just rehashing everything that happened and constantly coming up with new ideas. So some people get really calmed down by smoking cannabis because it just quiets everything down. And some people, find that cocaine is very powerful. I mean, cocaine and some stimulant medication, there's very, very little different chemical recipe, whatever it is. So, it just helps you to focus and helps you to get a label and just be clear. So you have similar effect, but with different needs, I guess. Yeah. And it depends on the people.
Yeah. Because it was an interesting conversation, because the patient I was speaking to said that they missed the effects of cocaine because they actually got things done when they were on it. They could focus, and rather than not hyping them up, they said, actually, just I could focus and I could remember to do things. And the people I was doing it with were high, and I wasn't really. I could focus, which is interesting because I've never seen that before. And she's been on the waiting list for 2 years now for the NHS assessment. It's a difficult time for her.
Yeah, no, and it's exactly what it does. And that's what stimulant medication does when it works. It just puts you at a set. I never knew what it was like to not have 100 thoughts in your head until I started stimulant medication. I'm like, oh my God, I can get things done. And it's one thing at a time. It's just a very powerful feeling. And usually drugs have a much stronger effect. And it doesn't make you high. It doesn't make you complete. It just makes you able to manage, which is very. We
have a question from Margaret Abbott. That's right.
I'm just picking up something in the chat, which I had the question as well. What sort of teeth issues do you mean?
So teeth grinding was one of them, but just very poor oral health. So the mixture of forgetting to go to appointments, forgetting to brush your teeth, then being discharged because you haven't turned up for your appointments and the clinics, the amount of bad oral health linked with ADHD is very strong, because of this combination of issues that makes it very hard to just care for your teeth.
Thank you.
So in terms of the other impacts, the link with mental health has been shown time and time again. There's some nuances with addiction. So we think about addiction in terms of substance abuse, but with gaming or porn addiction is also extremely common. Low self-esteem, risk-taking behavior. So the risk-taking behavior that we know, especially in girls, is usually risky sexual behavior, early pregnancies, unwanted pregnancies, unsafe sex, unprotected sex. So again, these are the kind of things that you might see in your practice. Now, I'm not saying that everyone who becomes a teenage mom has ADHD, but these are the pattern that has been linked time and time again. And prison. I mean, the rate of undiagnosed and unsupported ADHD in prison is it's just crazily high. So when we work with healthcare professionals, while it doesn't mean that, well, if you see this is ADHD, this is the kind of things to think about. Is there some eating issues? Is there some mental health issues? But on top of that, some other things. Is it someone that tells you, I've never slept well my entire life, I've always woken up 4, 5, 6 times a night, and I've got depression and anxiety, and I like smoking a joint to try to get me to sleep at the end of the day. You think, okay, hang on, is there a bit of a pattern here? And I'm just thinking about it. Because that's what you will see in your practice, much more so than you won't get a mum that will come to you and say, oh, she's a bit distracted in school, what can you do for me, right? You will see the big issues. So when we think about ADHD, we think that ADHD, well, there's been a lot in the press around ADHD is overdiagnosed. Everybody has ADHD now. It's a fashionable condition to have. And now the colleagues that I've worked with published this in 2018, where they show that only 1.2% of children with ADHD were being supported and 0.9% of adults. And this is a paper, the table comes from a paper that I have submitted for publication this month. And the main thing is the great written here. So we estimated the ADHD population on a 5% basis, and this is what it should be for young people, it's what it should be for adults. And we looked at every single databases and who is being treated only through prescriptions, so through medication. Now, there are other ways of being treated, and there's an understanding that only about 70% of any medical population will need treatment, because the 30% will not need it, can't take it for whatever interactions, or don't want to take any prescriptions. But even if you go on the 70%, only 24% of children are being supported in England right now, and 15% in adults. Now, this is data from April this year. So the whole concept of overdiagnosis and over, medicalization of ADHD, we're still so far from actually supporting everyone who might need it. We're just catching up. There's a lot more diagnosis. Yes, there's been a surge and a surge in demand on services, but that's because for so long they were underdiagnosed for so many years. So you have all generations of people my age, in their 40s, 30s, who were missed in childhood and are now catching up because their children are getting diagnosed because the awareness is greater. So it's not that there is over-diagnosis, that there's just more diagnosis catching up from years of being misunderstood or unaware. And this is a really nice study as well. Again, it was 7 years ago, so God knows what the numbers will show now. But back then, the UK was the third worst country from noticing symptoms of ADHD to receiving a diagnosis, with 32 months, and time from the first doctor visit to ADHD diagnosis was 18 months. It was the worst country in Europe, and things have gone much worse in the last few years in terms when it comes to ADHD. So I can only anticipate. I mean, these numbers will have gone better. It would just only have gone worse, but how much worse, I'm not too sure. It's quite interesting to show what it's like. I know. Well, we mentioned it about the local pathway, but in Nottinghamshire, the waiting time is really long. Now, just to finish on the kind of awareness of ADHD, I was just wondering whether you could think of these two case studies and think, who has ADHD, who hasn't? What would make you think that one is more likely than the other? What do you think would be telltale signs of things that you will see in your practice? Is there anything in there that makes you think, oh, because of that, I wouldn't think it's ADHD, or because of that, I will think it's ADHD?
So people can pop in the chat or unmute yourself and jump in.
It's a bit of a trial and error, see if anyone is willing to contribute.
That's it. I'm happy to say, so somebody's put unlikely. What are you referring to there? Presentation. Yeah, unlike the ADHD. I suppose, I mean, I'll let other people filter through, but from what I noticed about that is that I suppose the child that comes and sits quietly still in the consultation, appearing to be, engaged with it, it sort of draws you away from that diagnosis, and so they're always hyperactive and they sit there quietly, hands folded on the lap. That feels like you're moving away from it, at least from me, like if I'm talking very honestly here.
Okay, so that's a very interesting point. It's a point I've worked with GPs for quite a few years, and it's a point I've heard time and time again. Now, there's two things to consider here. ADHD is not just hyperactive, right? It's hyperactive or inattentive or both. So you could have an inattentive child that will find it very easy to sit in a 10-minute consultation. That. So hyperactivity is not the sole characteristic of ADHD, but also you have a concept that's so the concept of ADHD is not about being inattentive or just it's not about being able to control your attention. But sometimes you can overfocus. So if the child just happens to be in a place where you catch it at the right time in the right place, even though they're super hyperactive the rest of the time, then they will be able to stay still for conversation. Because you know what, the mum might have prayed them or not. I can never tell when my children will be able to sit still or not. We will go to the 11 o'clock cinema, session in Easton, and sometimes we can sit through and sometimes we can't. And there's no predicting that. And I couldn't tell you yes or no. So this is completely out of everyone's control, but this is definitely not a sign of yes or no.
So Lisa, would you like to unmute and make a comment? I see you raised your hand.
Yeah, it sounds very much like it's masking. All people with ADHD do tend to do a lot of masking, and because of the masking they get hypersensitive and they can very easily go into meltdowns. Whereas when they're not masking, they still can go into meltdowns, but it's more easier to manage. Both are definitely on the spectrum for ADHD. Obviously, more research would have to be done into it, but looking at both those case studies, yes, to me they both show factors of ADHD.
Yes, exactly. And Susanna said the same thing. Exactly. So these two children presenting very differently, some of them with behavior that you could expect for that age. A reserved 16-year-old is not that unusual, right? Some of them with traits that you might not necessarily think about it is good grades. Doesn't mean you have ADHD, therefore you have bad grades. Not always, but not often, actually. And the concept of masking is very strong. So again, for those of you who are not that familiar, masking is a term that you tend to use for autism a lot more, but it's extremely present in ADHD. And it's this concept that you mask, you pretend to be a high-functioning person, or you work the same as your peers throughout the day, whether it's at work or at school, depending on your age. And then you go home and the mask falls off, and usually it leads to a meltdown. It's just trying to function in society that doesn't fit with you, and just trying to be who people are expecting you to be. And in children, this leads to huge meltdowns after school, because home is a safe place where you can be you, and you just spend the day trying to not interrupt people, trying to not impulsively shout out answers during the class, trying to understand the rules of the game so your friends don't get mad at you. And then you get home and it's just a bit too much. And this is where children just usually have these struggles. And that's very hard, because part of the diagnosis process is to get reports from parents and reports from teachers. And in that case of Josh, you will have a teacher that say, oh, it's fine. Sometimes he's a bit fidgety, but all boys are fidgety, aren't they? But I've never seen any huge thing. But then the mum is like, yeah, but every time when he comes from school, I'm dealing with massive meltdowns and him, hitting on his sister or just really refusing to do things. And so the behavior might be very contradictory, and it's not always supported by school, which we do see as well. And the same for Abby. I'm not saying that all these, you will see these traits, and it will definitely be ADHD, but this is why you will tend to see in 16-year-olds a lot of mental health issues, self-harm, suicide attempts, eating disorders. These are patterns that we've seen a lot in undiagnosed girls. Difficulties with friendships and risk-taking behavior, whether it's starting smoking cannabis, starting smoking full stop, or drinking, unprotected sex, just any behavior that is just a little bit too much. So I just have two more for you when we're thinking about adults. So who do we think have ADHD? Who do we think doesn't?
There was just a quick, so somebody just mentioned some of the comments from the previous one. Somebody's talking about risky behaviours and mental health difficulties could be comorbidities. Both are features. Somebody said need further assessment, and somebody's asked, is it possible to misdiagnose ADHD?
From a secondary care perspective, the specialists usually are highly trained and will not be able to misdiagnose ADHD. However, at the first step level, there are lots of traits that can be very similar. So I know, for example, bipolar has very similar traits to ADHD in adults. So whether it's bipolar or ADHD, whether it's ADHD and or autism, that sometimes can be very difficult to know until a full diagnosis process has been done, until the interview has been. So it's possible to not be sure earlier on, but clinicians are usually, I've never seen a clinician that has diagnosed ADHD and it turned out that it wasn't. But there's lots of other. So trauma is also really highly, like the signs of traumas can be very similar to the sign of ADHD in childhood or the behavior of children. So this is why only your psychiatrist and your very experienced secondary care workers can make that decision. Well, is it trauma? Is it attachment issues? Is it bipolar or is it ADHD? or autism, or like where's the interaction? And usually when misdiagnoses happen, it's not so much, it's not ADHD, it's just there's a lot more complex issues, a child in care or a child, so it's just looking into that as well. And there's more to it than ADHD rather than it was never ADHD. Does that make sense? I've never seen that, but yeah.
I suppose the question I'd have with that is there was quite a prevalent Horizon documentary about getting having an NHS assessment versus a private one, and the NHS consultant not making diagnosis in 3.5 hours, and the other ones doing a 45-minute assessment, diagnosing and treating, with the person not thinking they had it in the first place. So have you got any thoughts on surrounding that?
That's very controversial, and I could spend a whole hour talking about it. Now, just a couple of things on this one. I didn't watch a documentary deliberately, but actually one of the surveys, the private service that I work with, was part of this documentary. Now, what they didn't show in the documentary is that when you get to the appointment stage, there's a very strong screening process where you have to answer questionnaires, you have to do a telephone screening interview to make sure just so someone doesn't go and spend £2,000 on a diagnosis that meet the criteria for. And the only way you go through this screening questionnaire is if you tick yes to all, if you meet the criteria for an ADHD diagnosis. So what I know about the documentary, this person wasn't very transparent about what he did to get to the assessment. Now, not all, but a lot of private clinicians will have a whole process before that you wouldn't go through if you didn't meet the criteria. Now, it's very easy to lie about a diagnosis if you know what you're lying about, right? This person obviously has a strong interest on ADHD and will know will have to know what to say in order to pass through the screening processes. So once you know what it will look like, what it has to look like, then it's a bit. If I know all the characteristics of depression because I work in it, I could get diagnosed with depression tomorrow if I wanted to. But the issue we're having right now is that ADHD private services are not controlled, and there's no regulations around them. And there are some very good ones, and there are some really poor ones. There is a whole bunch of things that need to happen when you get to that diagnosis. There needs to be interviews, there needs to be a report. When you initiate medication, you need to be checked with EEGs and blood pressure and weight loss, because we know that that's what happens. And places that don't do that are actually really, really worrying. And places that you need to meet the person in person, online diagnosis. So there's a lot of issues, but these clinics are popping up left, right, and centre to address a need that cannot be addressed by the NHS. And right now, there's no regulations for them. And so in Nottingham, we have guidelines around private diagnosis, but it's very hard to control. So it's not straightforward.
That is a really challenging thing, isn't it?
Yeah. And I'm sure from them you can be misdiagnosed. But if the diagnosis process has been followed rightly, it's just there's no way of controlling for all this private practice, but some of them are fantastic.
Yeah, brilliant. Well, thank you for that. That's been a question that's been across my mind for a while. Sorry, back to the case studies there.
So, has anyone got any strong feelings on either of those? So, as you can imagine, just like the children, they both will meet. They both could be ADHD. The training program that the online program that I've showed you right at the beginning has a GP with ADHD. Corey, she's this amazing woman who I've worked with, and she manages to talk. She does videos throughout the training program, and she talks about her ADHD as a GP, and she explained how it affected her medical learning, what she sees, and in herself she busts a lot of the misconceptions around ADHD about the fact that she's really high functioning and high achieving. She's a woman. All her brothers were diagnosed with ADHD and she was never picked up because she didn't show the same way. And on the surface she might look really high achieving, but you don't see the history of depression, anxiety, and the differences, the way this affects our mental well-being, like the perfectionism that tends to come with having ADHD when you're quite high achieving and high functioning, the tiredness that comes with it of masking and just pretending to, well, not pretending, but just having to be always okay. Now, I am not saying that Jen, you see someone like Jen and she has ADHD. What I'm saying is that for me, there would be quite a few hints of, if there is history of depression and anxiety. It's not just a one-off. She's not just going through a bad time because her marriage is a bit on the rocks, or she's a perfectionist. She does have a lot of empathy. I don't want you to walk away and think, oh, everybody who does that has ADHD. It's not, but it's just trying to think slightly differently about ADHD. It could be your really high professionals, but it is also the recovering alcoholics, the ones that are going from one job to another, that are moving house all the time, that have a history of, this is more your atypical undiagnosed adults that you will see on the right. And one thing that I did want to say, actually, that I forgot to say, is that, ADHD is highly hereditary. Usually, a lot of adults now getting diagnosed with their children have got a diagnosis. So neurodiversity runs in family. So if you see children with a diagnosis, look at the parents. Just think, you know what? The chances that one of the parents has ADHD and or autism is very high. Let's just think about it next time they come. If they come with a bit of depression or feeling run down, or saying that, it might not just be the burden of looking after the kids. It could be, also an element of undiagnosed diversity behind that. So let's move on to care pathways. So this is a very, very basic way of representing the care pathway. The patient will make an inquiry, and then the GP of the school will gather some information, and then the GP sends a referral to the specialist services. So, I'm sure you're all aware, I'm not teaching you anything, but GPs don't diagnose and don't treat ADHD. The only time they will come across medication is if there's a shared care agreement in place with the practice. But GPs are gatekeepers. Without the referral, usually you cannot access services. There are some places where you can self-refer. There are some places when the schools can do it for you. But most of the time, you guys have this key role of gatekeeping and allowing people to access. So there's not a strong need to understand all the ins and outs of ADHD in terms of, what kind of medication or what dosage or whatever, because that's taken care of in secondary or tertiary care. But it's understanding enough to be able to pick it up. And this is why I was trying to think differently about what might come across in your practice, in terms of other risks and other way it might look like. Now, secondary and tertiary care looks very different, whether it's children or adult services. The adult services, I was just reading a paper today, actually. There's only 44 specialist adult services in the UK. 44, when you think about all the different areas, how many areas are lacking? And so in East Midlands, I know Leicester doesn't have one, Derby doesn't have one, Sheffield didn't used to have one, but they might have one now. And Nottinghamshire is the only one locally, if you think about who is around us. And we're very lucky to have an adult service, but not many areas don't. And when it comes to children, it can be CAMS, it can be community pediatricians, it can be local councils, it can be psychiatrists. So it's very different. Who is in charge of the diagnosis and the referral process changes a lot depending on where you are. And I will tell you a little bit more about the local pathway, but this is the kind of idea. And as you know, the pathway depends on so many different factors, whether shared care agreement is in place. So I found that in areas of Nottinghamshire, the whole areas are now taking on shared care for medication, whether there are adult services, where you get the referral from, whether you can self-refer off or not, the type of treatment that you will receive. So depending, for example, here, if you're in city or county, you will get access to some form of non-pharmacological interventions, but there might be difference depending on where you live. The training of healthcare professionals, the awareness and understanding around that will be widely different, and the waiting list. But again, I will mention the local landscape in a minute as well around all that. Something to bear in mind that I didn't put on those slides is that the issue with adult services, aside from being completely over subscribed and few and far between, is in terms of transition from children to adult mental health, transition from children to adult services. So Nottingham is a big university town with 2 universities and one of the biggest GP practice for students in the country. And we are having a lot of children who either had been supported their whole life and then come here and they can't get their medication because there's no shared care, they moved away and there is no services to pick them up. Or what we do know is that, as I mentioned before, big life changes will tend to make people really struggle with ADHD. So you might have managed your entire life, you had a really supportive family, supportive friends, you might have had a few struggles, but it was completely fine. And then you leave home, you become independent, you come to uni and everything crashes. You have to be self-sufficient and it just doesn't work. And you need the support. And this is where the impairment from ADHD really comes to play. But then you're being put on a waiting list of for 3 years, but you're only doing your degree for 3 years here. So by the time you go through the waiting list, you will have to start again somewhere else. So this transition is a big issues, all over the country, but in the lack of continuity between services. And this is where a shared care agreement can make a huge difference. Because if someone is already being supported and treated, but is just moving to uni or moving home, then the lack of being able to get those medication when there is, so I think just for prescription, there's a 9-month waiting list at the moment in the adult services. So you come to uni, you can't get your medication because your GP doesn't have a shared care agreement, and you have to wait 9 months to get seen again for someone to confirm that, yes, you do need this medication, and you have a psychiatrist spending time prescribing you when you've been on it for 8 years or 5 years. So again, there are lots of issues and things to consider when making those decisions. But yeah, think also about the transition and the kind of population we have in Nottingham as well. So I'm kind of assuming most people are local, but even if you're not, this is very interesting in just kind of seeing the local landscape. So I run the Nottingham Neurodiversity Network, and we work with community pediatrics commissioners, GPs, CAMS, adult services, and I've spent a very long time developing this pathway infographic where we see all the different pathways locally. And they're all completely different. It took 18 months just to create that infographic and 26 versions, because it's just so hard to get your head around what's happening where and get it right. Now, I'm assuming you'll have a copy of those slides. So if you scan the QR code, there is a detailed pathway of every single area. So if you're in county, you can get your pathway for county, what happens at pediatrics, what happens at single point of access, and so on. Now, let's compare how things work locally. So your adult service is quite straightforward. You go to the GP, then you get referred, then you wait for years. Now, the adult services is, things are really likely to change. But last time I spoke to them, they were commissioned for 600 referrals a year. They're getting 400 a month. They have a waiting list of 7,000. So right now, the waiting time is 3 years. But you can imagine the people are joining the waiting list now. It's not going to be 3 years. You're not going to get 7,000 people in 3 years when you're commissioned for 600. And the waiting is getting longer and longer and longer and longer. And there's nothing in place in in all that. Now, I've shown you the risk in terms of mental health, the higher likelihood of committing suicide or having substance abuse or going to prison, of all these adverse life events happening. Now, if you left on a waiting list for 9 years, what are the chances of these things happening in the meantime? When it comes to the children's services, I'm just going to focus on city and county because it's kind of easier for communication level. But if you're in city, you go to the BH team, which is changing its name very soon, so it won't be known as that anymore. But this is the city council team. It's not an NHS team, it's not CAMS. So at no point do you go to CAMS on this. CAMS doesn't take part of the ADHD diagnosis in Nottinghamshire. It does in other areas of England, but not in Nottinghamshire. It will only look into it if they come to CAMS for mental health, and I think there might be more, but then they will send it back to those services. So I know a lot of GPs that work with locally send straight to CAMS, and that's not who deals with it. It's the single point of access, and it's Bay team in city, NST in county. Now, the Bay team has a waiting time of, I think, 12 to 15 months. And the NST team, my daughter has just gone on to this referral, and it's 27 months right now for the NST. And then from there, you go on to community PIDS, and in community PIDS is where you will receive support and diagnosis. So now, the main thing that to take into consideration, every single area would ask for proof of graduated response, what they call a graduated response. You need to show that you already tried to put things in place to support that child or to support that, the adult services doesn't, to have a referral accepted. And this is where the GP has a really key part in it, for the GP and the schools, because when you fill up a getting to know me form or whatever form is required for your services to show the reason for you referring for diagnosis, they will ask for this graduated response, sometimes pretty clearly and sometimes not. And what they want for that is to show it's not just a one-off behavior. We didn't have Mr. Smith coming in and say, oh, my child is being a bit, it doesn't listen at school and I want an ADHD diagnosis. It's like there are some issues, and with the school or with other things, you have tried to work at them, and it's still issues. So, for example, for my daughter, we've seen a speech and language therapist because she's almost nonverbal. We've seen the occupational therapist. We've been seeing the sleep clinic for about 3 years. Those are all indicators of neurodiversity, and this is where, even though she's only 4 and she hasn't been at school to show any support from school, I can show that we've tried to address these issues, and there's still issues. And in school, it would be like, well, okay, we know that Johnny tends to sit and just be very distracted in class, so we've given him movement breaks, or we're doing this for him, and we're doing that. And we have done this because there's a need here. So a lot of GPs have come to me saying, well, why is my referral being rejected? And usually it's because of that. There's not information on that. All it says is the parent thinks it's ADHD, and the services can't do anything with that. So the same with the services, they're getting about 500 to 600 referrals a month, each service, and they don't have the capacity to deal with that. So they need to make quick decisions on, is it worth putting on a 2.5-year waiting list? Do I have enough information? Because nobody wants to wait 2.5 years to find out at the end of the queue that you don't have enough information for that, or you don't meet the criteria for ADHD. It's not ADHD, it's actually more related to trauma and to circumstantial, where you are at a time because of a child in care, for example. So depending on where you are is very important. Also, for example, if you're in city, they accept self-referral, but they don't accept that in county. So what you can advise your patients, depending on where you are, is also varies widely. But finally, in terms of the GP, I don't know if everybody knows that, but something to remember is that everything is based on the GP practice. So where I live is very typical, where I'm between city and county. I live in Beeston, which is county, but I work at the university, which is city. And who you're going to see as a family doesn't depend on where you live. It depends on your practice. So if I am with CRISPS, which is the medical center here at the university, I will be on a city pathway. But if I am in Beeston, I'll be on a county pathway. So you as a practice will always have the same pathway, but the people who come to you might be in county or city. It's not the school, it's not the home address, it's the GP practice that counts of where the child goes. So anyone living on the border of different areas, really remember that, because it doesn't depend on the family situation, it depends on your practice. That's something I didn't know before I started working with the group, and I found that and not many families knows, and not many schools know either. So you might have a school. They go to a school, for example. So you're in city, but they go to a school in county, and in county in the school they will say, "Oh, you need to go to an ST team, and this is the kind of support you're expected to get." And then you will say, "No, actually, because I'm the GP and I'm in city, and this is the pathway." So you might have different conflicting information on your families for anyone on the.
Yeah. Can I ask a little bit of a question? A couple of things there. So I think you might be coming to it in future slides, but is there one thing that I have a lot of families struggle, particularly with literacy levels, to accurately and confidently fill in a fairly complicated form? Is there any support around to help with that, charities or support groups to help them fill in the multi-page form? Because again, it seems quite challenging.
So it depends on where you are. I know the Bay team has support with translation, and they will call the parents, they will put things in place, and actually the county team as well. So there are charities, there are local charities. There is Autistic Nottingham that can help with that. I know we're talking about ADHD, but and there are a lot of private. So I've got a list of resources that I will send at the end of the slides that you can use in terms of thinking about what other supports can help with that. Yeah. But yeah, in terms of literacy and language, there are some support out there. So I just don't have them on top of my head.
That's fine. The other one was, again, it might be a future slide, but because the waiting list is so long, and particularly if we're trying to gather information or support them in the meantime, have you got any suggestions how GPs might be able to support people while they're waiting diagnosis? Because we've got 2.5 years or however long it is, but and again, my colleagues might echo this in the chat, but we will see people a lot of times with either escalation or frustration, and a lot of our consultations now are, essentially the problem is I'm waiting for secondary care referral, and not just in this, in more or less every specialty.
Yeah. So so a couple of things there. I have put some resources, local resources, training and strategies for broader understanding, but also things you can refer back to and send them to. I mean, the online support is amazing. ADHD UK is fantastic. Attitude, sorry, that's supposed to be double D's, but Attitude is a fantastic source of support for anything to do with ADHD. And just understanding, I think what I was explaining to you about the impact of sleep, the impact on mental health, just to think about what other things they struggle with. Is it the mental health issues? Is it the sleep? Will that help? I know, if, for example, a child is really struggling at school and is about to be expelled, can maybe working on these other things support that to a degree? Now, there are also a lot of local organizations that help with school lack of attendance or school refusals, or because usually that's what parents really worry about, is the behavior of their children in school and whether they will be able to succeed academically or not. So yeah, there are resources out there on that. Again, there's quite a lot of local support, and I've put a resource pack together that I'm happy to send to people to just kind of signpost the families to. But so aside from signposting, when it comes to all the other things, I don't really know what else you can do apart from, because you're not here to provide the support. But But the support you can maybe provide is thinking of, is there anxiety or depression? Maybe can medication on that help? Is there a risk of suicide, of self-harm? Is there a risk of substance abuse? Are they self-medicating? Are they sleeping or not? And is there, will supporting the sleeping, for example, help while they're waiting? It's not a solution, but it's just this little bit of support on all the other things. I'm just going to finish quickly. I was just going to mention the neurodiversity network that we did, and we did a workshop last week that I run, and the workshop was around understanding different roles within the neurodiversity, and this fantastic person came and captured all this. And I know this is very messy, but she separated, and this was the GP. So we had a GP that came and talked to just really clarify the roles around what you do and what you don't do. We do not diagnose or treat, but we can support, and we are the first point of call. And just try to clarify. So if you want to look at this infographic, just try to think all the different services around Nottinghamshire and what their roles are. And in terms of what to do, so what you will see in your practice, it is usually people seek a diagnosis when at crisis point, and this is very hard because they want help right now. They've been living with that for a long time, and it hasn't been bad enough for them to seek help. But then they come to you and it's like, okay, my kid is just about to be expelled. I'm about to lose my job. Things are really unraveling, and I need help. And then you're putting them on a pathway where they can't get help for 2 or 3 years, and that's really hard. But usually the parents will say they can't cope, the children don't fit in, they're just struggling. There's often strong different behavior at school and at home, and they might not look like they have ADHD. They might have problems with sleep or mental health. In adults, they might have substance abuse, history of change of jobs or addresses, someone that keeps changing jobs all the time, keeps changing home, and history of mental health, with little effect of mental health medication, of antidepressants, will be kind of the telltale sign of what kind of pick. And in terms of referrals, just think about this graduated response, understanding your care pathway depending on where you are and where you work. Is it ADHD or not? Just think about the other overlap, but usually GPs are not in a situation where can I make that call. Why is my referral being sent back? Usually it's because we don't show the graduated response, or there's not enough information. Trying to liaise with schools, and understanding demand on local services, the waiting time, the support they do and don't offer. Again, I work with all the city and county and Basset Law, and I know the resources they have, the kind of support that they can give pre and post diagnosis, but they also have, once the referral is sent, they also have a lot of pre-diagnosis support within those services that are really useful for families. And yes, there's just a bunch of resources you can have. I mean, I always signpost everyone to Attitude, just because Attitude is very simple, short articles that people refer back to for everything. The effect of hormones on ADHD in women. My child is refusing to get dressed. What do I do? Just very practical advice on lots of different things, ADHD. Sorry, I'm just 1 minute from finishing. I thought I would have extra time for questions, but I've been whizzing through that.
Well, it's been really wonderful. Thank you so much, Blandine. That's we've covered an absolutely huge amount, whizzing through, but just such a big topic, and I think there's that it really hammers home just how much more there is for us to learn about ADHD. It comes up so frequently in our practice, more or less every single week I'll see a couple of people that are concerned about this, and also thinking about some of the case studies that you presented. Then actually some of the people who are not coming asking about ADHD, but actually thinking about whether it might be relevant, particularly with some of this frustration and meltdown, and that really struck home to me on a few things. Now, Fortunately, you said we don't have to rush off for a couple of minutes. So if anybody has got any final questions, please pop them in the chat. But if people listening today have enjoyed it, the best way you can show your thanks to our wonderful speaker who's given up her time this afternoon to speak to you about this topic is please do the feedback. Let us know what you thought. Let us know what you enjoyed and more events that we might be able to do in the future. And we'd really love to have Blandine back for some more education around this if she'll have us. Yeah, it's just been really great and enlightening and eye-opening. So thank you so much.
Thank you, James. And I just want to say my email is on the slides. Like any questions, feel free to email me. You know, we all want to work together, and So I've got no problem people emailing me personally about anything, any question they might have.
Fantastic. Right, I did invite a couple of questions. We've got somebody here is wondering about the patients with cardiac illness and ADHD, mainly tachycardia, and issues with memory. Do you have links to anything to do with ADHD and cardiac illness, so physical illness and ADHD medications?
I think it came up in our, so it's not the field I work in at all, but I do think it came up in a systematic review in terms of cardiac issues. I think it was mainly linked to obesity, if I'm remembering correctly. I just don't remember all of it. Yeah. Sorry, but there has been some links around epilepsy and diabetes, like more physical health issues. Let me just see, it's just there. So physical health. You know what, I won't be able to
that's it. Well, perhaps we can forward that on if we find something.
Overall health, please, excellent. Asthma, vision, diabetes, and cardiovascular diseases. So yeah, there's one review on that. If you email me, I'll try to find the link.
Wonderful, thank you. I've just popped the talking of links, I've just popped the link for the feedback back in the chat there. Please click on that before you go. If not, if you're the sort of person that will absolutely 100% check your emails and fill it in later, that's absolutely fine. But if not, no time like the present. So people are asking, are the slides going to be available afterwards? I think you've agreed to let us share them. Is that right, Blandine? Yeah, super. And I think that there's probably going to be recording about that as well, but give us a few weeks for that. But yeah, brilliant. And with any luck, we can do even more education about ADHD around this in the future. And very, very important. So thank you. Very important session. My notepad is full.